You're live.
Great. Hey everyone, welcome to the PFIC Network 2020 Educational Webinar Series. Joining me here for this first session is Dr. Jim Squires, and shortly after, Dr. Kyle Soltis will be joining us for the surgical talk. While we're waiting for the next minute, if everybody could put in their chat where they're from and introduce yourselves, we'll be able to get rolling here shortly. All right, Carrie, I think we could get the ball rolling. So again, I just want to welcome everybody to our educational series. This is our kickoff to our overall series. The medical treatment and surgical treatment options of PFIC will be today. Again, Dr. James Squires and Dr. Kyle Soltis, both from the Children's Hospital of Pittsburgh, will be our presenters for today. Go ahead and the next slide. The PFIC network is presenting these sessions. Our organization is supported by generous grants from both Miram and Albareo Pharma. And we also receive capacity building grants from Global Genes, and we're proud members of the Global Genes Rare Foundation Alliance. A few housekeeping things, a few disclaimers before we start. These sessions are meant to be for information and educational purposes only. If you have any questions or need medical advice, please consult your doctor, but you can absolutely use the information that you've learned in these sessions to have conversations with your physician. HIPAA is the Health Information Privacy Act that governs patient-sensitive information. Zoom is not a platform that is HIPAA compliant, so please be aware as you are asking questions that this platform is not HIPAA compliant, so please keep personal patient identifiers out of your questions. And lastly, these sessions will be recorded so that we can make them live on our website, and they may be used for promotional purposes to help guide our mission on social media, website, newsletter, etc. So please keep that in mind as well while you're asking your questions. So before we begin, I'm going to give everyone a little bit of background about the PFIC network. The PFIC network was founded with the intent to improve the lives of patients and families worldwide who are affected by PFIC. Our mission is rooted in 4 pillars: education, support, advocacy, and research. We are governed by a group of parent advocates from all over the world. My name is Emily Ventura, and I am Executive Director and co-founder of the PFIC Network. A little bit about me: my daughter was diagnosed with PFIC-2 in 2012. She's been through the wide range of the spectrum of treatment for PFIC, including medication. She had the external diversion surgery, and most recently she was transplanted in May of 2017. And she remains immune compromised from that, but is doing quite well. I'm an ICU nurse by trade. However, the demands of COVID these days and taking care of an immune compromised daughter has led me to a decision to leave bedside nursing for the time being and focus on my leadership role for PFIC Network and the organization. Go to the next slide, please. We work with a medical advisory board who represents institutions from all over the country and other areas of the world as well. Our medical advisory board helps us to prioritize and create opportunities as deemed necessary by the needs of our patient community. Next slide. A brief history about PFIC Network. PFIC.org, the website, was created in 2002 by another mother who wanted to know more information about her daughter's illness. In 2007, the social media support group was created by yet again another, actually a patient who has PFIC, because she wanted to find support in a community of others. In 2017, the founder of PFIC.org reached out and asked for help. So myself and 2 other parents stepped up, and we saw the need to create an organization to take her vision forward. So in 2018, the PFIC Network was created. Our initial focus was to bring the community together to provide education and support and raise awareness. We did that by hosting the first ever PFIC Family Conference in June of 2019. Shortly after that, we created the first annual PFIC Awareness Day, October 5th, 2019. And after that, we had some momentum and we built in the direction of providing peer support programs that would help our patient community. So those were created this past June of 2020. Those include a financial assistance program, a bereavement program, care package program, and mentorship programs. And following that, we created a parent and patient advisory board to help us identify further the needs of the community. Next slide. Right now, we are continuing to focus on assessing the needs of the community and identifying and documenting where the knowledge and resource gaps are so that we can create meaningful and sustainable programs. In August, we updated and launched our new website. That website hosts our first ever patient self-report registry, which we actually slowly rolled out a few weeks ago, and we'll be working on building momentum for the registry moving forward. Currently, we are hosting the virtual meeting series, which Dr. Squires is going to kick off here in a moment. And then next week, we have our second annual PFIC Awareness Day on October 5th. And from there, we are going to present our hospital outreach program as well, where we will be reaching out to over 50 institutions worldwide to introduce, our community to new patients. And then coming up into 2021, we're going to shift focus to growing and responding to the needs of our global patient community by putting together a global patient and parent advisory board. So now we're going to lead into the educational webinar series. This series is designed to have a live Q&A. However, I am going to moderate all questions. So if you do have any questions for our speakers, please locate the chat feature. It's either on the bottom or the top of your screen. You can ask your question at any time, and I will relay your question at the end of the session for an open Q&A. Okay. So I think without further ado, I'm going to turn it over to Dr. Jim Squires, and he can further introduce himself and get us going.
Hey there, guys. My name is Jim Squires. Let's see, trying to learn to share. It says host disabled participant screen sharing. Next there. I'm trying to figure this out. So I'm a hepatologist at the Children's Hospital of Pittsburgh here. And so Emily invited me to give a talk today about the current and future medical management of PFIC. So let's see.
You should be all set now. Sorry.
Got it. No, you're good. All right. So, Sharon, okay?
Yep.
All right. Do you see the full screen, not just the note slides?
I see both.
Oh. See both.
Yep, I see the notes on the right and a panel, and then your slides are on the left.
Okay, hold on, let me then. Apologize, always some technical issues, technical hiccups. So again, Jim Squires here from Pittsburgh, going to talk about the current and future medical management of PFIC. So, just to start off with a little bit of background, and again, I know most people on this webinar are familiar with this, right? But we have learned a lot, and things have changed a lot over the past 50 years or so. On the left there, what you see is what we call the differential for neonatal cholestasis in the 70s. And again, as I'm sure many know, neonatal cholestasis is how children with PFIC typically present as babies with jaundice. And so back then, the vast majority of kids that attained this diagnosis received a diagnosis of neonatal hepatitis, which was kind of a wastebasket term for we don't really know. And over time, as of this past decade, there's really been an evolution of the field, and we have been able to drastically minimize that kind of big pie piece that was neonatal hepatitis into many other kind of known diseases, many of which have a genetic base, both either with metabolic or cholestatic liver diseases. I think focusing specifically just on the intrahepatic cholestatic diseases, which is, what this talk is primarily about. I think, again, very familiar to many people here, this has historically been referred to as PFIC, or progressive familial intrahepatic cholestasis. There are three classic conditions, the PFIC 1, 2, and 3, with deficiencies in the FIC1 protein, the BSEP, and the MDR3 protein. I think several people in the field as kind of new diseases are being recognized or thinking about moving away from the term PFIC, but I think it's pretty much baked in to the literature and likely is not going to go anywhere anytime soon. Again, I think this is a review paper that's now about 5 or 6 years old. Many people may have read about it. And not to go too much into the details, right, of the differences between the three kind of historical PFICs. But, here we have PFIC 1, again, presenting in infancy, end-stage liver disease generally progressing over the first decade. That's the natural history. Obviously, we now have interventions that my colleague, Dr. Soltis, will talk about next that may prolong that. Course of disease is generally described as moderately or severe. Pruritus or itching is obviously a devastating complication of the PFIC1. Extrahepatic manifestations are present, which makes that unique. Risks of liver tumors are thought to be minimal, if at all. Cholesterol stone disease has not been described very well. You see, again, ALT has some mild elevation. ALK-Phos is typically, AFP, or a marker of tumor, is typically normal. GGT, again, normal or low, with bile acids being high. Liver histology showing a bland cholestasis. I think differences between PFIC1 and PFIC2 a little bit is that the age of presentation, PFIC2 generally occurring maybe a little bit later, although can be early in infancy. PFIC2 is generally much more of a rapidly progressive disease, so the liver disease can be much more severe. Pruritus, again, is often very severe in this condition. Typically does not have extrahepatic diseases, although the risk of tumor is much higher. Again, you see the biomarker abnormalities as well as the liver histology differences that have been described. And then lastly, PFIC3, again, PFIC3 sometimes described as a cholangiopathy. It's interesting to think about PFIC3 as how closely it relates to some of the other PFIC disorders. I think that it was historically grouped with PFIC, but probably has a little bit of a different pathophysiology. And again, some of those things are laid out in the differences that were put forth in this review. But as many of you also know, the diseases which are defined under PFIC are really ever expanding. And so although, the times, they are still changing, right? And they're changing quickly. I think that's one of the things that is most dramatic, right? So if you go back to 2014, this is when that review that I just mentioned was published, right? So it was published in March of 2014. Just 1 month later, right? April of 2014 is when the first description of the TJP2 phenotype was released in Nature Genetics. In 2016, we began to understand how mutations in the nuclear bile acid receptor for XFR also caused the phenotype of low GGT cholestasis. 2017 was the first report of Myo5B without microvillus inclusion disease, which is the more classic bowel disease that associates with Myo5B mutations. This was described in hepatology. And then most recently in 2019, from the King Faisal group, I think doing some genetic studies on, again, children, most of which whom had parents who were related, but how some of these recessive disorders were manifesting as the phenotype of PFIC, which is a low GGT cholestasis presenting in early childhood, with kind of 4 more additional genes identified to cause the disease. And so I think when you think about PFICs, right, and the place where we as physicians often go to learn about various diseases is a place called PubMed. It's kind of a medical library of all articles that have been published in various journals to date. I think going back, to when PFIC was first described, right, which was in the early 90s, there were 2 publications in 1994 that if you search the words PFIC, came out, right? And, as of 2020, right, we are up to 21 publications just this year alone. And so I think we have learned we've learned, a whole lot about these diseases and how they present and about many of the genes that associate with them. And so this was a review that our group put together a few years ago that kind of in a pictorial fashion really puts all of the kind of 6 most common PFICs into kind of one picture, whether it's, again, the FIC1 protein or the MDR3 acting at the canalicular membrane, the BSEP protein, which pumps the bile salts across the membrane, Myo5B, which again acts to kind of localize BSEP, or obviously FXR, which interacts with RXR to promote ABCB11 or BSEP production. And then, TGAP2 is a tight junction protein off to the side there. So this is kind of, over the past couple decades has been what we've learned from a pathophysiology standpoint about the PFICs. And so, I think we've learned a lot, right? But I think if you think about PFIC as it relates to maybe some other medical conditions, right? So if you take that same PubMed search engine and you put it, congenital heart disease, this is the graph you get, right? And I think you'll notice some important differences, right? So this goes back to 1879. So they have a lot more data, right? They are already publishing into the future, right? So 2021, there's already articles that are being published about this. And if you look at the most recent set of data, they have 13,326 articles about congenital heart disease in the medical literature just this year alone. So we've learned a lot, but we have a lot to learn. So I think, specifically what, Emily asked me to talk about today, and I want to make sure I go through with enough time for questions at the end, is the treatment, right? So if you go back to 1994, the main treatments for PFIC was, there was no really any definitive therapies. We talk about supportive measures. And so these are improving things like nutritional deficiencies and managing the complications of their progressive disease. Well, if you skip, ahead a couple decades to 2020, unfortunately, as I think many in this audience know very well, very little has changed in that. We do have some additional surgical options, mainly diversion, and I'll let my colleague, Dr. Soltis, talk about that in the next talk. But as far as pharmacological therapies, we really have made very little progress in kind of combating PFIC. But there is still the future, and I think we will definitely end this talk hitting up some of the ways in which we hope in the future to be able to change this slide, so that when I give this talk next year, we'll be able to have a little bit more information about how we can treat these diseases. But I think it's important to kind of look at some of those historical measures that we take and those supportive measures that we take, and talk a little bit about why we do that and how it affects the specific PFIC disorders. So first, again, improving nutritional deficiencies, right? So this is your typical growth curve of a child, and this is the kind of the way that a child with PFIC often tracks. They are often small and often struggle to gain weight appropriately. So if you ask why is it that children with PFIC have difficulty gaining weight? This is where we get into the importance of bile and really the importance of bile acids. And so this is a picture that I think many probably have seen similar pictures before, and we will come back to later in the talk, but goes over kind of, where bile salts come from, right? And they mainly come from, cholesterol and the breakdown of cholesterol. That forms bile salts, which then are excreted out of the liver into the intestine, where they act as emulsifiers. And we'll talk about how they work from that standpoint. They then travel through the GI tract, most of which are reabsorbed in this at this terminal ileum, this end of the small intestine, and then kind of recirculate through the body in the intrahepatic circulation. So again, if you think about the functions of bile salts, bile salts essentially act as detergents to help break down fats. That's why they work. I think we've all had that experiment back in grade school or high school where you take oil, you mix it with water, and they separate out because they don't mix very well. So as we eat fats and are trying to absorb those fats across the membranes of our cells, which are mostly water, you really need a detergent or an emulsifier to break down those fats into a size that we can then get across the cellular membrane. And so that's what bile acids essentially do. Bile, they get into the small intestine after being secreted from the liver. They interact with these large fat droplets and emulsify it and break them down into much smaller particles that are then able to be absorbed across the enterocyte, or the cell that lines the GI tract. And so you can imagine if you don't have bile salts, or you don't have that ability to break down fats very well, you can't absorb fats. Fats are critical for nutritional development and for growth. And so for children with any cholestatic disease, this is obviously not unique to PFIC, but with any cholestatic disease, children aren't able to grow and gain weight very well. So again, just a picture showing that when, in the PFIC disorders and other cholestatic diseases, if you block those bile acids from getting out of the liver and into the intestine, you aren't able to gain weight very well. And so again, the sequelae of this is fat malabsorption and failure to thrive. So how do we combat this a little bit, right? Can we mitigate it? Can we improve some of this? Well, the short answer is a little bit, right? And the way that we do that is in part by looking at some of the differences in fats and fatty acids. Again, many in this group may know that there are different types of fatty acids. Not all fats and fatty acids are the same. They are typically broken down into what we call short chain, medium chain, and long chain fatty acids. And when you actually think about those different types of fatty acids, there is a different propensity of those to be able to be absorbed across the membrane of the intestine. And it's actually the medium chain, not, people would think it was the short chain, but it's the medium chain that's actually able to cross the intestinal cell with the easiest amount of work from bile acids. And so, long chains and short chains typically need a lot of emulsification in order to pass, but medium chain are actually able to pass relatively freely without the emulsification bile salts needed. But if you look at kind of where these different types of chained acids come from in our diet, you see that, the long chain and the monounsaturated as well as the short chain, these things are really common in our diet, right? So a lot of the foods that we eat contain some of these long and short chain fatty acids. The medium chain is very limited, right? In this pictorial, only coconuts. There's a few others, but the point here is that there's not a lot of natural sources of medium chain triglycerides. And again, the importance of medium chain triglycerides are these the ones that are able to cross and be absorbed by the child without much help from bile salts. And so often what we will do in medicine is try to supplement with things that contain very high amounts of medium chain triglycerides. I didn't have a disclosure slide. I have no disclosures to announce. I mainly just kind of picked these two products from the internet as pictures, right? I don't have any stake in progestamil or anything like that. But progestamil, which is a formula, and there are others that are kind of supplemented with increased medium chain triglycerides, as well as MCT oil supplementation, is things that many of your children will often be prescribed. And the reason we do that is, again, to try to get them to absorb as much fats as they can, recognizing that the cholestasis is likely to persist. So again, I think, the other thing that we see when you can absorb fats very well is the deficiency of fat-soluble vitamins. There are certain vitamins that are dependent on fats. These are the A, D, E, and K variety, again, with a picture showing where a lot of these come from. And if you don't have fat-soluble vitamins, or you have deficiencies in fat-soluble vitamins, you'll have symptoms from that. And so again, vitamin A is very important for vision, reproduction, bone health, immune, and skin integrity. And so with vitamin A deficiency, you'll be deficient in many of those things. Vision problem is kind of the classic one, and night vision more specifically. Vitamin D for bone strength and calcium absorption, which is why many children with PFIC as well as other cholestatic diseases often have bone health issues, and we worry about fractures. Vitamin E, again, with the immune system and as an antioxidant in general. And then vitamin K, I think most importantly with blood clotting. Again, I think something that probably many on this webinar know well, the importance of vitamin K as it relates to that INR number and the ability to clot your blood appropriately. And so again, in children with PFIC, oftentimes in order to try to mitigate this, we will supplement them with fat-soluble vitamins in addition to other things to try to mitigate these deficiencies. And so really, with fat-soluble vitamin supplementation, plus, increasing the amount of medium chain triglycerides that are consumed in the diet, we can take a child that really is starting to fall off the growth curve and get them to gain some weight, but we often are not wholly successful in getting them to attain kind of a full potential of what is likely their growth. And again, a lot of this is due to the progressive nature of the liver disease. And so again, small stature often persists, despite therapy, despite our kind of best efforts. So kind of moving on, right, I want to talk a little bit about, if we're thinking about treatment of PFIC, is oftentimes also the treatment of cirrhosis, or the treatment of kind of progressive liver disease, because these are progressive liver diseases, particularly if they are more complicated. And so when I think about progressive liver disease, there's kind of two buckets that I think about management and where treatment can lie. One is in the development of cirrhosis or scarring of the liver, and the other is the development of kind of liver dysfunction, where the functions of the liver begin to wane. So if we take kind of the cirrhosis bucket first, it's important to recognize that the liver has a very unique anatomical placement in that it has inflow blood supply from both the heart and the intestine. And this comes in through the hepatic artery and in through the portal vein, with a single exit that is the hepatic veins that then pump things back into the heart. There's various segments, and if we get a little bit more granular, I think this is kind of kind of a much more focused look at kind of how the liver is actually built. Again, you have blood flowing in through this portal vein from the intestine, in from this hepatic artery. Blood is then kind of transverses through the hepatocytes to this central vein, where it then is pumped out back to the heart. And again, one last look showing really how the blood kind of comes together, mixes in with all the hepatocytes so that the liver can actually do its function by absorbing nutrients, and then the importance of bile flow, where actually the toxins that are absorbed and processed from the liver are then pumped out back into the intestine. And so, if you look about this, right, and you think about progressive liver disease, these are kind of normal looking, liver cells here. But if we start to develop scar tissue or other evidence of disease within these livers, the ability of the blood to flow naturally through the liver is obviously compromised. And when you get higher pressure of blood trying to flow through a liver, you get what we call portal hypertension. And portal hypertension is in itself, kind of a complex phenomenon that has a lot of potential complications to it. So again, I live in Pittsburgh, and when I try to explain portal hypertension to families, I kind of use the rivers as an analogy because we're a city of rivers. Here you have the beautiful, Monongahela here, and this is the Allegheny up here, and they kind of come together and form the Ohio River, right? And so again, if you think about this in cartoon form, again, you have your Allegheny up here, your Monongahela down here, the Ohio River. And if this is kind of the blood that's coming together to form the portal vein to get into the liver, right? If you were to develop portal hypertension, that's essentially like going out to the Ohio River and dropping a dam on the Ohio River, right? And so what are the natural effects of that? Well, you're going to have a backup of all the water that's trying to get through. So the Monongahela is going to get big, the Allegheny is going to swell, but what you're also going to get is some of those tributaries, those runs, those other small kind of rias that are emptying into these larger rivers, even ones that you may not have noticed were there are going to kind of expand and get bigger. And so what we see clinically with that is what we call esophageal varices, right? And so this is where you get abnormal kind of swollen blood vessels where normally there wouldn't be some. And one of the most problematic areas that you get that is in the esophagus, or the food pipe that takes food from the mouth to the stomach. And so this is a picture of an endoscopy kind of looking down the pipeline, and you see these kind of swollen blood vessels here. And these can burst and these can bleed, and this is one of the complications we often watch for in kids who have portal hypertension. There are other complications that portal hypertension can cause, many of which revolve around kind of volume and electrolytes and the circulation of fluid. They can develop ascites or hepatorenal syndrome. There are other syndromes like hepatopulmonary syndrome or portal pulmonary hypertension, which can be complications of liver cirrhosis and portal hypertension. And at the end of the day, there are very specific treatments that we often use to combat these individual processes. I won't go through those in detail, but I think if any on the webinar's child has developed them, you recognize some of those therapies. And these are not unique to PFIC, but they are critically important as you think about the complications that can develop from PFIC.
Dr. Squires, let me interrupt just a second. You have
Yes,
an idle timer image on your screen that you drew. I'm not sure if that'll...
That popped up there. Okay. Sorry about that.
Got it.
Go away.
Yep, you're good. Thank you.
Apologies. So then I think moving on to kind of the second bucket, which is chronic liver dysfunction, right? So if you think about chronic liver dysfunction, the first question you have to ask is, well, what does the liver do? So again, a very kind of overly simplistic picture of kind of the various things that the liver does. But the important point here is that if you think about what the liver does, as the liver starts to fail or starts to develop dysfunction, many of these things will themselves begin to not work well, and you'll get symptoms from that. And so these are many of the symptoms that you can see in someone who has chronic liver disease. Hypoglycemia, because glucose control is done by the liver. Low albumin, because albumin is a protein that's made by the liver, so you'll get ascites. You can get coagulopathic, as we talked about. Fat-soluble vitamin deficiencies, malnutrition. Immunodeficiency, a lot of people don't think of the liver as an immune organ, but it absolutely is. Again, hyperammonemia, and some of the way in which our body handles medications and drugs, the liver is involved in all of that. And so again, there are treatments that we will often deploy that target very specific complications that relates to these various functions or dysfunctions. We already talked about kind of, ascites, coagulopathy, fat-soluble vitamin deficiency, malnutrition, and poor growth, as well as some of the things that we do to try to combat that. Cholestasis is another big one, right? Cholestasis is a broad term that defines the ability to get rid of bile salts, bile acids, and everything that contains within bile. The treatment for cholestasis, if you can't treat the underlying condition, which in PFIC we talked about is still a challenge, one of the things that we use most commonly is ursodeoxycholic acid, right? Ursodeoxycholic acid is a synthetic bile salt. It gets its name from, if anybody's a constellation guru and knows Ursa Major, Ursa Minor, that's the Big and Small Dipper. Urso means bear in Latin. And so this is actually synthetic bear bile that we make ourselves. There is a small amount of ursodeoxycholic acid that humans make, but we give this to supplement bile because bile does undergo what's called bile-induced bile flow. So the more bile you have, the easier things flow. And so patients with PFIC will often be described ursodeoxycholic acid. There is literature about some improvements that have been noted on children specifically with PFIC2 and BRIC2, where ursodeoxycholic acid has seemed to make a difference in their phenotype. I think when you look more broadly at ursodeoxycholic acid, it is a medication that has a very good safety profile. I think in many of the diseases that we treat, it can make the numbers a little bit better. So it can make the bilirubin come down. It can maybe make the GGT improve a little bit. But oftentimes it hasn't really been shown to improve outcomes and endpoints in kind of clinical trials. That said, again, given its safety, many of us will use ursodeoxycholic acid to treat our patients with PFIC. What about hyperammonemia and encephalopathy? Again, this is a complication more related to that portal hypertension, but also can be related to kind of liver synthetic dysfunction as the liver is breaking down urea into ammonia. This is a pretty late stage complication of end-stage liver disease, but can be a very devastating one if anybody's had a hyperammonemic crisis. So again, where does ammonia come from? It comes from the intestine in our gut. We absorb urea. It's supposed to be processed by a healthy liver. When the liver can't do that, either because the blood doesn't get there because of portal hypertension or because the liver isn't working well, you can develop ammonia accumulation, which can pass into the brain actually and cause swelling, which leads to other complications. And so we will combat this aggressively. The medications that we use are pretty old. None of them are new medications, but things like lactulose, neomycin, flagyl, rifaximin, a lot of these work to try to prevent, at least in the intestine, the absorption of ammonia. There are other diseases where they'll use actual scavengers to suck up the ammonia that's in the blood. Often in end-stage liver disease, these have not been as successful, but there are therapies that sometimes children with PFIC will need in order to help control their ammonias. I think probably most important to this group is the management of pruritus, again, itching, which is one of the most profound and I think devastating manifestations of this disease. So this is like, when you Google image itching in a child, this is the image that comes up. And I think, clearly not what we see when we see PFIC kids, right? Typically what we see is something more along the lines of this destructive kind of deep abrasions where these kids are really tearing at their skin because the itch is so severe. Itch is terribly frustrating because we, and when I say we, I mean the medical community, we still don't really know what exactly causes itch. And I think there are several theories. Many of them have data behind them, but we don't know for sure. And so this picture kind of tries to capture what causes itch, but there is some data that just the increased bile acids in the blood contribute to the itch. Autotaxin is another molecule that's been associated with itch. Lipophosphatic acid, or LPA, is another substance that we think causes itch. And again, as you've seen in this picture, they put in a factor X, right? Because there's likely other factors that are in there because of different studies that have been done that show that it doesn't seem to just be one of these things, and or it's a combination, and or there's a factor we still haven't described. Whether or not that factor acts on peripheral or central signaling to kind of signal the nervous system to cause the itch is still, again, somewhat of a debate. But I think that the more we learn, the more we are trying to understand how best to combat itch. But we still, by no means, are perfect at it. There are various medications that we will use to try to combat itch. And again, many, I'm sure, of the parents on this webinar have had children who have either been described, again, ursodeoxycholic acid, which is another medicine or another utility of urso in patients with PFIC, rifampicin, which is a PXR agonist that increases metabolism and has an antibacterial effect, cholestyramine, which essentially acts in the intestine to bind bile acids so that they don't get reabsorbed. Naltrexone, which is an opioid antagonist. I think a lot of people can relate to when they get morphine or another opioid. There's an itch that sometimes is associated with that, and so naltrexone is an opioid antagonist, has been shown to be beneficial. And then sertraline, which is actually an antidepressant or an SSRI, has also been shown in children and in adults to improve itch in a certain population. I think most of the time that the clinical approach is a trial and error. I think I've had many patients who I've tried on all of these medications only to start over and try again. I've had them on various combinations of these medications. I've had them on medications that I started, didn't seem to work. Went around the block, and when I came back, restarted a medication that seemed to have some improvement. And so itch is, one of the most devastating things to have to witness in a child, and it's one of the most frustrating things to try to treat. This is essentially the entirety of our armamentarium from a pharmacological standpoint. Again, Kyle, who's just joining us, will talk a little bit about some of the surgical aspects that we use to treat the itch. But from a medical standpoint, this is essentially where we top out, at least here in the United States. But what about the future, right? What's in store for us tomorrow? Because there are some future therapies that I'm sure many on this call are aware of and are interested in. I think the biggest one being the IBAT inhibitors. And again, IBAT stands for ileal bile acid transporter, and that is that protein that sits in the terminal ileum down here at the last part of the small intestine, whose job it is to reabsorb bile salts in order to recycle them back to the liver. Many think that the liver disease that progresses is in part due to bile salts reaccumulating in the liver. And so if we can block that, you can potentially slow down the disease process. Again, IBAT inhibitors work by blocking reuptake here, therefore increasing the amount of bile salts that are kind of lost in the stool. Again, just another picture about how these medicines work, kind of binding to that channel in the terminal ileum and blocking the reuptake of bile acids. Benita Kamath and Hankin and Verkade, Benita's in Toronto and Hankin's in the Netherlands, just recently published this review of the potential of these IBAT inhibitors in both Alagille's, which is another liver disease associated with terrible itch and cholestasis, and the PFIC disorders. I think Philip Stein, who's from Alburio, is also a co-author on this. And again, not to go through this entirely, right? But I think when they looked at maralixabat, which is one of these medications, the target indications you can see here are for PFIC as well as some other cholestatic diseases in children. I highlight here the key clinical finding to date, which is that you get reduced serum bile acids in pruritus at week 48 in an open label phase 2 study, the Indigo study, which some maybe on the call have participated in children with PFIC. I note that the current status is that the FDA has given this breakthrough therapy designation for PFIC2, and that a phase 3 PFIC study, the March study, is planned. I think when looking at the other IBAT that's on the market today, the otoviximab, again, target indications are for PFIC, Alagille's, and BA. The key clinical findings to date is that there's been improved bile acids in pruritus in a phase 2 dose escalation study in the PFIC populations, and that a phase 3 study and an extension are underway. And so I think, this is where a lot of people are very excited about IBATs. We talk about this as a chemical diversion, and I think it's something that holds a lot of potential for particularly, the itch that is the most devastating complication of this disease at times. There is a recent paper that was put out by Eckhard Strum from the German group looking at, again, one of these IBATs and how it related to partial external biliary diversion. And what they showed is essentially these two acted equivocal. As part of the trial at Eckhard's institution, it was essentially you started it and then you stopped it. There was an end date. There wasn't an open label extension. And so here you can see what the child's bile acids were at baseline. They were increasing. They started the IBAT inhibitor, and you see that they dropped dramatically after a couple, 6 weeks. But this trial called for an end date to the therapy, and there wasn't an extension offered, so they had to withdraw the medication. You see that the bile acids went right back up over the course of the next couple of weeks when the child underwent a partial external biliary diversion, and they dropped again. And so this, again, kind of goes back to the point that these IBAT inhibitors seem to act almost as a chemical diversion, which is obviously preferred to a surgery in and of itself. What about some of the other therapies, right? So I think this is some older data from a few years ago, but something that I still think is worth investigation and more thought, right? So this was a paper that was put up by the Netherlands group, and again, they looked at a cell culture, right? So this wasn't in humans themselves, but were in cells. But what they saw was that these trafficking molecules, right? So there are many medicines that have been coming out, particularly in cystic fibrosis, that look at kind of improving the trafficking of particular proteins to kind of their correct locations in a cell, and how some of these traffickers could affect, in this case, ATPB1 as a therapeutic strategy. And what they showed is that, again, in cell culture, if you gave these medicines, you were able to improve the protein functioning, A, getting to where it needed to be, and B, its function in cells that were acting like PFIC patients. I think, here's another paper that was in JPEDS a few years ago looking at 4-phenylbutyrate, which is, again, one of these chaperone proteins that we think of helping certain, or chaperone molecules, helping certain proteins get to the correct location within the cell, showed that it improved function and pruritus in a child with PFIC type 2. This paper that came out from Dan Doyle looking at a regimen for PFIC 2, and again, this is really an N of 1, which means, just kind of in one single patient using both 4-phenylbutyrate, an IBAT inhibitor, and oxcarbazepine. And again, you can see the dramatic improvement in itch in this particular child. So what's holding us back, right? Why haven't we been able to make better advancements in this field, right? Well, one of which is, again, the rarity, right? So when you're competing with 24 articles a year versus 13,000, you're going to be behind the 8 ball a little bit. So this is still a rare disease. I think the other problem is, mice are not equal to babies. And in PFIC in particular, what we know is that there has not been a great animal model that's been developed that can kind of recapitulate or redevelop all of the symptoms that we see in children. And there's reasons that we know behind this, right? So again, this is now an old paper, but essentially showed that if you activated certain proteins in mice, they have compensatory molecules that kind of kick into gear so that you don't get the full PFIC phenotype, right? So the story out of this paper was that a BSEP knockout mice, and when we say knockout, we mean you kind of destroy that protein in the animal so that you can develop the phenotype, are not a valid model for reproducing PFIC2 because there are species differences in the function of hepatic transporters. So if you knock out BSEP in a mouse, there's other transporters that kick into gear that allow that mouse to not develop the full phenotype. Right? And then we've been able to understand that, again, this multi-drug resistant protein 1 compensates for biliary excretion in BSEP mice, right? So this is the protein that kind of increases in order to allow BSEP knockout mice not to develop the phenotype. In FIC1, when we've knocked out the ATPAB1 in mice, there are different mice strains that we will use, and depending on the strain that you use of the mouse, you haven't really been able to, there's vast differences. So we haven't been able to kind of recapitulate the human disease. So there has not really been an animal model that fully recapitulates human disease. So how can we overcome this? Well, the fact that it's rare doesn't mean that we can't look to increase our numbers, right? So this was from, again, that recent review that our group put out. And what essentially what it shows here is that, these proteins, there is increasing evidence that deficiencies in these proteins causes disease in adults, right? So we typically think of PFIC as pediatric disorders, and for sure they mostly are. But I think if you can increase your numbers by showing that these deficiencies in these proteins also cause morbidity and mortality in other populations, mainly adults, you'll be able to increase the numbers and increase awareness and increase interest and increase understanding of these diseases. And so there is emerging evidence that these do cause disease in adult diseases, and so I think that's going to be important. And then again, coming back to this lack of established animal models, how can we improve that? Well, I think there's various ways to do that, right? And I think some of the more exciting ones are, I think using cell models of disease, right? And so by this, I mean, you take a patient, we now in science can take somatic cells or skin cells or any type of cells from a patient. We can take them into the lab and give them certain signals to back up and to become what we call inducible pluripotent stem cells. A pluripotent cell is a cell that has the unique potential to become many different types of cells, right? I always give if you think about how a human comes to being, you get a cell from mom, a cell from dad. You start off as 2 cells, 2 become 4, 4 become 8. And along the way, there are certain signals that direct certain amounts of cells to, you got to come over here and be a skin cell. You go over there, you're going to be an eye cell. You guys come with me, we're going to be liver cells. And so you can back these cells up into a stage where they're kind of inducible, right? And then re-signal them to become any type of cell you want. And so if you can take cells from a child or an adult with PFIC, back them up to become inducible, make them to become liver cells, you can do various things, right? You can take those cells and do kind of cell studies like that that one group did, looking at trafficking molecules to improve BSEP. You can use those cells and then do kind of patient-specific targeting of medications to see how certain medications can improve that particular defect, and then that then can cause drug development or spur drug development, which can be given back to the patient. Or you can go the other way, right, and take those cells and actually modify them, correct them, reinduce the single protein that was defective, grow those cells out, and then potentially inject those back into the patient for cell replacement therapy. A lot of these are still very much in their infancy, but it has been done, right? So this was from scientific reports. This was the generation of bile salt export pump deficiency, again, using this model. So they were able to take a patient's cells, back them up, redevelop them to become hepatocyte-like cells, and then they were able to study that particular disorder, kind of back in the lab. I think another kind of exciting but kind of moonshot type approach is there's also the ability to take a mouse, actually give the mouse an injection of a certain medication or other toxin, which essentially kills the mouse cells. You can then take human cells that have been harvested either with IPS or other ways, inject them into the mouse, keep the mouse immunosuppressed, and essentially make a mini human liver within a mouse. So that you now have a mouse with a human liver with whatever disease you want to study in that mouse. None of these are perfect. These are all very much in their early stages, but I think these are ways that I think hopefully over the coming years and decades we'll be able to better understand these diseases, better design treatments, and ultimately better treat our patients. So conclusion, unfortunately little has changed in the medical therapy for PFIC despite growing understanding of the diseases. Currently, novel therapeutics and clinical trials show promise, but definitive studies are needed. And ultimately, future efforts combining technological advancements and basic science may enable improved therapies, faster pipelines, and more personalized approaches. So I think that's the last of my slides. I'll stop now. I think we still have about 15 minutes for questions. I'd love to answer anything anybody has.
Great. Thanks so much, Jim. That was incredible. Okay, so if anybody has any questions specifically, I want to remind you, you have that chat feature that you can use, and I can moderate questions. For those who are joining us via the Zoom link, you can hit the raise hand, and we can allow you to talk. I just want to remind everybody that if you do ask your own question, please keep patient identifiers out, and please keep your own personal stories out. Just kind of ask the broad questions so that we don't get into those HIPAA violations for your patient privacy. Okay, so I'm going to get started. And Dr. Squires, let me clarify, you have to run shortly after 3, but you'll be back, correct? At 3:45.
And yeah, Kyle's on now. I have to, interestingly, right? So I'm actually popping off to join a call where we're trying to do just one of those last things that we talked about. So we've got a study here where we're taking, skin cells and inducing them to become hepatocyte-like cells and then trying to study them. So I'm trying to get a couple collaborators together in order for us to advance that project, which is exciting. So that's what I'm going to be talking about. And then I'll come back and answer questions after Kyle's talk at the end.
Awesome. Okay, great. Sounds good. So yeah, if we don't get to all the questions, we can ask more questions to Dr. Squire after Dr. Soltis' talk.
Absolutely.
So we did have a few questions come in beforehand, so I'll get started with those. Can you briefly explain, these two kind of go together, what the difference is between low GGT and high GGT? And there's another question about the subtypes, and we see them labeled differently. We see 1, 2, 3, and then we see, all of a sudden we see all these, different genes. Could you maybe describe the difference in the subtypes and then the low GGT and the high GGT?
Absolutely. So, GGT or gamma glutamyl transferase is essentially it's a biomarker of cholangiocyte injury, right? So cholangiocytes are the cells that line the bile ducts. And so most cholestatic diseases in children, most of the big ones, Alagilles, biliary atresia, many of the other primary sclerosing cholangitis, these things have very high GGT. Because oftentimes when you have obstruction of bile flow, the cholangiocytes, or those cells where the bile is trying to get out, are going to be one of the first places that's damaged. So the liver numbers are also high, but the GGT is typically high as well. Unique to the PFIC disorders is that the GGT is low. Now, why that is, I don't think is very well understood, right? Why GGT in these disorders is low is something that I think has always been of interest to people. And something that I think cues us in clinically when we see that baby for the first time in clinic, and we check their liver numbers, and the bilirubin 6 and the ALT, AST are in the hundreds, and the GGT is 12, right? Because there's very few things that cause that, and they're essentially all of these PFICs. Because any other disorder, the GGT is going to be high. I think that part of this goes back to kind of the intro slides where I talked about the kind of classic 3 different PFICs as well as the additional ones. PFIC is an umbrella term. PFIC describes a phenotype of cholestasis in infants, right? And what we're better understanding now is that this phenotype many times has a genetic basis, and there are specific genetic abnormalities that associate with the various phenotypes. And so, I personally, am trying to move away from using the term PFIC because I think it's too generic. And I think now we very much understand specific protein defects that lead to these diseases. And this is why I kind of alluded to a little bit, right? I mean, I think PFIC3 in particular, probably, again, it was put into the category because it was one of these canalicular, kind of proteins that sit in a certain place within the hepatocyte, that its dysfunction led to disease. But it seems to be a very different beast than the PFIC 1, 2, 4, 5, and even 6, right? I think it's also important to recognize that particularly PFIC 4, 5, and 6, the TJP2, the FXR, and the MYO5B, we are talking about incredibly small numbers of patients that have been identified, right? Like handful, maybe dozens, less than 100 for sure. And so I think, what's allowed us to identify these patients is advances in genetics and genomics. But I think that we still don't really understand these diseases in full. They're grouped into PFIC because, again, of their phenotype. And when I say phenotype, I mean the physical manifestations with which they present. But I think that, the numbering, I think, needs to stop, right? Because I think I showed that last slide where there's now like 5 new ones that have been described by the kind of the Faisal group in Saudi Arabia. Because we're going to learn more and more. We're going to identify more and more genes that cause this type of phenotype, of these physical manifestations. But at the end of the day, it's the protein defect that's the problem. And so I hope I answered the question there. But I think that at the end of the day, the different subtypes relate to the specific protein that's defective, and that's where the numbering comes from.
Great, thank you. Okay, I have a few questions that are rolling in live, so I'll get started with those. First of all, is there any reason to be concerned about long-term use of rifampicin since it's not specifically for PFIC, it's in the class of an antibiotic?
Yeah, we don't think so. Rifampicin, generally is thought of as an antibiotic that, it's an inducer, but it's also not it's one of these kind of not very well absorbed medicines. The short answer is we don't really know, right? I think it's important that we don't make declarative statements, here. But I think that we generally think of it as a very safe medicine that people can be on for quite a long time. It doesn't necessarily have that systemic effect the antimicrobial effect that we think that will induce kind of resistance and things of that nature. But I also don't think that this has really been studied in a meaningful way that can help assuade those that may have reservations about being on, kind of long-term antibiotic use.
Great. Okay, next question. How do you explain that there are some patients that do thrive despite a very aggressive form of PFIC? Specifically, this one always had 95% growth percentile with no progestamine, and then went into end-stage liver disease at 6 months. Can you describe the variability?
Oh, I mean, it's an excellent question and one that we struggle with all the time. We see variability even, so here in Pittsburgh, I have the advantage of being able to care for a very unique population. We see all, but one that we see quite a bit of is PFIC1 deficiency, the Byler's kids, right? Byler's disease is another name for this PFIC1. And the Byler is actually a family name of an Amish Mennonite cohort where PFIC was initially described. The advantage there is that the genetic defects in these patients it's identical, right? A lot of times you get a group of PFIC patients together and they all have a very unique defect as it relates to their particular protein, where the problem is. And I think when you start to drill down into specific protein defects, sometimes you'll see things emerge. I think the NAPIC group has described a little bit differences in BSEP and PFIC2, looking at the differences in different types of protein defects as it relates to how they manifest. But sometimes even with a very homogeneous population where the defect is exactly the same, you will see vastly different phenotypes. And so again, probably there are modifiers that we just haven't been able to understand, right? There are probably other things about that patient's environment and genetic underpinnings that enable them to have a little bit of a different phenotype. So, that's one of the things about this disease I think that fascinates me most is the variability that you see across all patients. I think the more and more though we learn about specific genetic defects, hopefully we'll be able to kind of group and have some better understanding of subpopulations within FIC1, BSEP, MDR3, where specific therapies may be better targeted towards even this subpopulation of a PFIC than kind of more PFIC broadly in general. And I think that's another important, just kind of sidebar, right? I mean, we call them PFIC because they're so rare, and when you group them together, there's a little bit more power with numbers. But these are probably very different diseases, at a kind of a molecular level, right? And so as you think about therapies and pharmacokinetics and interventions, it may be that, we find one medicine that's going to work great for a subpopulation of FIC1, but doesn't seem to have an effect at all in MDR3. And so we won't know until we try some of these things. And again, we're excited about the IBET trials and all that's going to be coming out in the near future. But, we call them all PFIC. It's probably a little bit presumptuous to then think that there's going to be one treatment for all PFIC.
Yeah, that's fair. And I want to circle back to that in a question if we have time, maybe at the end of the later session. If we have time for it, I have 2 more that are live here. So this one's a bit specific. So are there any downsides to not taking medications for itching other than the fact that the itching goes away? So for example, if the liver is able to get reprieve by having bile pushing through that is less sticky, maybe it's less upset, maybe cirrhosis doesn't develop as quickly. And I think this is in reference to their daughter forgets to take meds and obviously notices when the itchiness increases, which is concerning for a parent, not taking the meds. But is there any other spin that they can put on that to sell her on the importance of taking meds?
The short answer is probably not, right? So we don't necessarily think, or there's no evidence that itch correlates with any particular more severe liver disease, right? The most devastating thing about itch is just watching a child be miserable itching. But there's no evidence to suggest that somebody with a worse itch has a worse liver disease, right? I think the question from before about growth in development, kind of underscores that as well. I think that the degree of bile acid elevation that may be present in a child. Now, does that mean that there isn't an importance to it? We don't know, right? No one's ever done a study where they've kind of serially followed bile acids to see if certain bile acid elevations associate more with a more rapid progression of a disease, right? We just don't have the data to be able to answer that question. But I think, lowering the itch, I don't think necessarily means that we're controlling the disease any better. I'll put it that way.
Okay, and then what about, this is just kind of my question based on that. So what about ursodiol? Because, so is ursodiol helping to slow the progression of the disease in that matter, if we take the same question but apply it to that medication?
Yeah, so the thing about ursodiol, again, I kind of alluded to this before as well, right? The data on ursodiol more generally is that it makes numbers better but doesn't change endpoints in almost every clinical trial that it's ever been studied. Still, at the end of the day, if you give me a kid with a bilirubin of 6 and a GGT, or and liver enzymes in the hundreds, I start them on urso, and I get the bilirubin down to 2, and the liver enzymes down into 50 range. I just can't. It's hard for me to kind of square that isn't making a difference, right? Even though all the studies tell me that I'm not saving that kid any more time off of a transplant list, or I'm not making this liver last any longer than it naturally would. So we use urso because it generally makes numbers better. And it's hard for us to not think that those numbers being better has a difference in the outcome. But I think when they've actually looked very closely at that, it doesn't seem. Now, again, they haven't looked closely at that at PFIC, right? There's been no long-term, trials done in PFIC, that have, shared any meaningful data. So we're kind of gleaning this from, again, biliary atresia, PSC, and other kind of diseases where there's higher numbers. But I think we use urso because it makes numbers better, and we hope that numbers being better reflect a lower degree of damage being done to a liver.
Okay, I feel like I could pick your brain about that for another hour, but I know we don't have time. Do you have time?
Yeah, sure. There's a bile acid specialist in Cincinnati you should talk to.
Okay, well, we'll have to get that name. Maybe we'll host another webinar.
Sure.
Okay, one maybe quicker question before you have to leave, and then I do have another one for you when you get back. But can you, sorry, I lost my question there for a second. Why are PFIC2 patients at higher risk for liver cancer?
Yeah, I don't think we know that. That's been one of the kind of mysteries that I think a lot of people are trying to study as well. I would actually flip it to say, why are the other ones not at risk for cancer, right? We see cancer develop a lot on the background of a very sick liver. So kids, again, who have biliary atresia, kids who have, kind of other progressive chronic liver diseases. Hepatocellular carcinoma is one of those risks that you always watch for in someone who has a very sick liver, particularly one that's kind of scarred down. So I think, probably BSEP follows more what you would expect, although, there's probably caveats to that. But I think what's interesting is that, kids who have FIC1 and other of these diseases, they can have very sick, fibrotic scarred livers, but to date, there's really been no description of kind of cancers developing in that population. So, it's an area of an intense study. Again, I think these are the questions that we need to study and hopefully overcome some of those, mechanistic kind of basic principles that hopefully advances in kind of the lab setting will help us be able to get models to be able to better understand why exactly. Because I don't think we're ever going to get it in the numbers, right? I don't think there's ever going to be enough numbers of PFIC2 patients to be able to, really draw a whole lot of great, meaningful data. Even in the large kind of NAPID, where the numbers are big, it's a 50,000 foot view that you're getting in those kind of registry studies. To really kind of study this, you're going to need, the ability to kind of get a mouse model and make, hundreds of thousands of kind of livers to kind of really understand what's going on. But we're working on it. I'll try to answer that better next year.
Okay, great. Well, I will ask you next year.
Sounds good.
Okay, it looks like you probably need to go to your call. There's one other question related to the GGT, but how about I ask you that when you come back? I
can answer now, but I also want to respect Kyle's time. He's been on.
Ask as many questions to Dr. Squires as you'd like.
Okay, well, how about we ask this while it's kind of like while the
really hard ones would be perfect.
Give me one more. What's one more?
Okay, so back to the GGT discussion. It was mentioned that PFIC shows normally low GGT, but this person in their children, they show high GGT. So she's wondering if that means that they're abnormal for PFIC. And also off of that, there's been a huge delay in diagnosis. So she's wondering if maybe that could lead to why there's that delay.
Yeah, so again, I think it's important to recognize when we talk about these things as low GGT, high, We try sometimes in medicine, and probably a little too hard, to put things into buckets so that we can understand it better and so that we think that we can study it better. But there are exceptions to every rule, and there are plenty of children out there who do not read the textbook. So just for every child who's supposed to have a low GGT cholestasis, but the GGT is high, there's a child out there with Alagille syndrome who presents with the GGT being low. So I think that, we need to be very careful that, if I see a kid with the GGT that's low or GGT that's high, that I shouldn't rule out entirely one of the, PFIC1, BSEP, TGP2, or MYO5B or FXR mutations that is typically associated with quote unquote low GGT. At the end of the day, I think particularly in these disorders, at least currently, the genetics is where I think we need to put the focus, right? So if we have a child with a liver disease that we can't put our finger on, and we find a mutation in BSEP, but their GGT is 400, I don't care that the GGT is 400. This kid has a defect in BSEP, right? I mean, the genetics is showing us that. Now, again, is there another modifier that is having this patient be a little bit on the oddity with a high GGT? I don't know. And it's going to be hard to understand that. But I think, we as clinicians, it's always our, I think, to due diligence and say, well, just because this kid isn't fitting neatly into, this written down definition of what I'm supposed to see when I see PFIC, it doesn't mean that it can't be ruled out. So, and I think that extends beyond PFIC, right? I mean, I think that, we need to do that in many instances where, I think vice versa as well, right? I think the flip side of that is, we've had children who come who, for all intents and purposes, I think this kid has a PFIC, but the genetics are all normal, right? Well, guess what? That's probably just because we don't understand everything about all the different genes just yet, right? And this is why there's TJP2 and FXR and MYO5B, right? Because if those kids had presented, 15 years ago, they did, there's no BSEP deficiency. I mean, this is how TJP2 got identified, right? Is that these kids, for all intents and purposes, everyone thought it was BSEP, but when they did all the genetic testing, BSEPs were normal, right? And FIC1 was normal. So what was going on? That's when they went and they did extensive genetic testing, looked for other genes, and kind of found TJP2. I mean, that's how we're discovering new proteins all the time, is when you have a kid who's sick, but you're not able to find the gene, right? So it goes both ways. If the gene says there's a problem, but they don't fit the phenotype, you got to put some faith in the genetics that, there's still something going on there. If you have a kid who has the phenotype, but doesn't have a genetic diagnosis, that doesn't mean there's not a gene that's answerable to this. It just means that we haven't identified it yet.
That's fascinating. Thank you.
All right, I'll let Kyle go now. I'm going to jump off. I'm going to, work on studying PFIC, and I'll jump back on in a little bit and answer questions at the end.
Great. Thank you so much. And if anybody else has questions for Dr. Squires, just put them back into this chat and I'll keep a tally and we can ask him when he comes back. Thanks, guys.
Good luck, Kyle. It's a tough crowd.
Yeah, they seem rough.
Educated.
How are you guys?
Great. Dr. Soltis,
Great.
thank you.
Yep.
How are you? Thanks for joining us.
Yeah, I'm wonderful. Do you want me to put my slides up?
Yep. I'm going to give you the floor and turn me off.
Let's see. Let's see if this works.
You are good.
And then let me just do the, there. Does that look good?
Perfect.
Wonderful. Okay, well, thank you so much for the invitation. This is it's a wonderful group that you've actually created. This is it's an amazing opportunity, and I've given similar talks to much smaller groups, this is just it's been a kind of a lifelong interest of mine. We've done a lot of work with the disease, it's a very special population of patients to us. So that being said, let me talk to a little about the surgical side of management of PFIC, and I don't think I overlap too much of Jim's, which is good. And so when I talk about